to the discussion part, and I would like to invite all the speakers to take part in this discussion and the doctors to answer the questions. We have one question from the audience about glaucoma progression that was confirmed by perimetry and OCT, but IOP with medical therapy, I suppose with maximum medical therapy, was 18 millimeters mercury. And the question is, should we operate this patient? Should we take him to the operation room? I would like to address this question to Ninli Wan, of course, because he has spoken about normal tension glaucoma. If it is possible, please.
Yeah, it is my honor to answer the questions. Yeah, we cannot make a decision if we perform the operation on the patients or not. The IOP is one of the reason for us to make the decision. The most important thing is to see the progression. If the progression and even is stable, yeah, we can put the patients on the medication. If the patients have a strong, moderate, even stronger progressions, even the IOP controls on the target level, but we need to put the patients on the operation, means we can have the operation on the patients. So this is my experience. But for the most of the normal tension glaucoma, we have a three group of the people. Some patients, the progression of the vision field is very stable, even without any treatment. And someone with the treatment, still the vision field can keep the stable. And 1/3 of the patients, even the IOP have a good control. So finally, we have to do the operation and to lower the the intraocular pressure by 20 or 30%. This is our experience from our clinical aspect. Thank you. Thank you for your question.
Thank you, Ninli. And one more question, if it is possible, I would like to ask you a question. Because in 2014, we have a symposium, offline symposium here in Moscow, which was devoted to the translaminar pressure, translaminar cribrosa pressure, and our famous Professor Volkov was a chairman, and Jost Jonas was a co-chairman, and we discussed the same problem. The question is, what has changed from during the next years, and can we use this information in practice for our patients? Can we measure this pressure, and what can we do with this information?
Yeah, so for the translaminar cribosus concept, that give us some new informations for the glaucoma. We just not to think about the intraocular pressures. We have to think about the intracranial pressures. Both of them make the balance. If the patients have a lower intracranial pressures, can cause a higher translaminar cribosus pressures difference. So, but unfortunately, so far for us to measure the intraocular pressure is easy. Everywhere in practice, we can measure the intraocular pressures. But unfortunately, for the intracranial pressures measurement is quite difficult. So far, we have the non-invasive method to measure the intracranial pressure. So for the translaminar cribosus pressures balance treatment, so far we lack of the evaluation method technique to see if it comes to the new balance or not. So, so far, the most challenging questions is to design or we can created some new measurement, some technique to measure the intracranial pressures, especially the pressures in the subarachnoid around the optic nerve. Okay, thank you for your question.
And one more question. You have mentioned about the change of classification for open-angle glaucoma. Classification, what do you think? Is it feasible? What do we need for this? Some more investigations in genes, in vascular factors to change the classification of primary open-angle glaucoma.
Yeah, so because for the primary means so far we don't know exactly the etiologies, so we call the primary. But because the more and more information we got from the research, we found the normal tension glaucoma have so many different risk factors, just like the lower BMI, lower intracranial pressures, and deficient of the vitamin A, and some mild regulation of the circulation around the optic nerves. So even some phlegm syndromes. So there's many different new risk factors. Some is strong related systemic risk factors. Some is from the ocular risk factors. So we have to think about to make the new classification for the normal tangent glaucoma. The new classification means it's not just for the classification. The significance is to guide the doctors to treat our patients more efficiently. Just if the patient have a very strong risk factors from the systemic, so we have to treat the systemic disease. If the patients have the lower intracranial pressures, we have to think about how to increase the lower intracranial pressures. For the deficiency of the relative deficiency of vitamin A, maybe we can give the patients vitamin A application to increase the assistance of the optic nerves damage from the higher translaminar corpuscle pressures difference. So this is we just think about. So we need more evidence, information from our studies.
Thank you, Nili.
Thank you. Thank you.
Okay, Dr. Ramon Sazana, can you hear us?
Yes, perfect.
Oh, thank you. Can you tell your attitude to such kind of devices for intraocular glaucoma surgery? I mean Xen and PreserFlow. If I'm not mistaken, PreserFlow some years ago called like InFocus. Yes.
Yeah, you're right.
Yeah. Now we have PreserFlow. Okay. Let's just imagine a patient with a deep anterior chamber, probably after the phaco surgery or with a high myopia, and with glaucoma, and it's time to make a anti-glaucoma operation. What do you think, Xen or PreserFlow? Ab interno or ab externo? What's better?
It's a good question. In Brazil, the Brazilian FDA did not approve these devices to be used up to now. So we do trabeculectomy here whenever possible. But the literature is very huge on these two devices. It's easy to perform, but is related to more needling that is difficult. Sometimes difficult. You have to open the conjunctiva in the case of Zen. And you may have also extrusion that is not noted and so is linked with endophthalmitis. But it's an easy procedure, fast procedure, and for sure has a place in your armamentarium.
Thanks. Thanks very much. If I would like to move to your country, I will be very happy because in Russia we also do not have Xen either pressure flow. And my favorite surgery is trabeculectomy with some modification also. But do you remember Express glaucoma shunt?
Yes.
Well, we have in Russia the several cases of implantation, but not several, something like 1,000. And what do you think about Express?
Yeah, I will paraphrase the words of Professor Weinreb that it once told to me. I did some, I removed many. In Brazil, there was a boom, but nowadays very, very, very few patients are being have been performing surgery in very few patients with Express. Makes things easier also, but I don't think put a foreign body in the eye is a good option when you have a trabeculectomy that you can monitor very well, and is easier to do needling when you have a trabeculectomy than when you have Express in the eye. In Brazil, there was, I said, a boom, the pressure of the industry, but nowadays, very, very few surgeries with Express.
Also, what do you think about the antifibrotic agents, mitomycin C? Do you apply always this kind of treatment, antifibrotic agents? And if no, what can we expect?
Yeah, in Brazil, we use mitomycin C in every single case of trabeculectomy. Even congenital glaucoma, when you need to go to trabeculectomy, you use mitomycin C. Is the conventional approach here in Brazil. And they give us, as doing that, we have a lot of experience in how to do it and avoid the complications, or at least reduce the complications of the use of mitomycin C.
Other questions?
No, I think no, it's time to go.
May I ask one question to Professor
Thank you.
Tarek?
It is so nice to see you. Thank you very much, Armand, for your cooperation and your presence today with us. This is fantastic,
Natalia.
fantastic. Thank you.
You.